You're watching CTOM TV. Knowledge is power.
Okay, so we've covered a bit about HER2, what it is, and so on. The standard treatment involves a drug called doxorubicin, cyclophosphamide, and Taxotere, which is from the Pacific U tree. In short, we had the first targeted therapy was a drug called Herceptin, and it targets the receptor of the HER2, which is on the outside of the cell.
And how long ago was that created? Do you know?
Boy, that was back in 2000-ish, 2002.
Okay, so 17-ish years
remember.
ago. Okay,
yeah, I did
spot
remember it one time.
I'm sure you
I'm
did.
Getting old.
I'm just trying to do the math in my head.
It was the
that
first
was the very first one.
Yes.
Okay.
And then years later, they created another one that works on a different part of the HER2 receptor, because these receptors can get bent and damaged, or they can break off and start self-signaling. And so pertuzumab works on a different part of the HER2 receptor. I'm not going to get into which part and why it was designed, but it was designed basically for women that had been on Herceptin and stopped responding. So what we know now is a combination of the two drugs works really well together. And so that is a protocol that they call THP.
Okay.
And so that's paclitaxel or Taxol, Taxol-based therapy combined with Herceptin and pertuzumab. And so really, when you give this to patients in the neoadjuvant setting, in other words, prior to any treatment, 50% of patients get a complete response, a pathological complete response.
Okay, now for those at home,
So
what's
that's
a complete response?
So complete response is more than 30% of the tumors responding.
Wow.
And it's based on the RECIST response criteria, which I'm not going to get into right now.
But that's a good increase in survival.
It's a full response. It's considered a full response.
Wow.
And so it works really well.
That combination of those three.
Yes.
Okay.
Now, that's most patients, obviously most patients will get some response from this combination. So it's really the way to go.
Most HER2 positive patients.
Yeah. Now, if you have multiple lymph nodes and so on, then you want to consider adding the other chemotherapy drugs like doxorubicin and cyclophosphamide. And that would be a protocol called ACTHP. And so they're going to give that to a patient with more aggressive disease, infiltrating disease, and something that's much more aggressive. And depending on how many lymph nodes that are positive too.
Okay.
So what is new is, while Herceptin has been around for a long time, it's an infusion that takes 30 minutes. The same with pertuzumab. And that can be a bit of a problem. So in Europe, they've developed this process called subcutaneous injections. So it's basically a shot that just takes a few minutes. It just goes into the skin.
And that's how they deliver the treatment?
Yeah, and it's just as effective.
Wow.
I haven't heard a lot of it being used here yet, but it's the new way of giving it. And that way you can greatly cut down on the time and the cost, because having someone sit in the clinic for 30 minutes plus and hook up IV, requires monitoring doctors. So this subcutaneous way is really the way to go.
It's just a shot.
Yeah, now I just read a phase 3 study of subcutaneous Herceptin and pertuzumab. So it's both drugs given together really quickly.
Wow.
It's radically going to change how this is given.
Nice.
So I think that should be out fairly soon. It's the data's all there.
Yeah,
so
that's exciting.
Now we move into once you stop responding and the cancer starts coming back. And so this would be adjuvant or late stage, adjuvant onwards, as I call it. Adjuvant refers to after surgery, but I mean it's a pretty loosely described word because it can mean various things. I just like to say neoadjuvant and adjuvant. And adjuvant, in my personal opinion, should include everything that goes beyond surgery, everything that's been done as a secondary treatment. So second treatment onwards, and that's kind of how I refer to that.
Okay.
So in later lines, there's lapatinib. It's been around for quite a while.
So could I, just to clarify, this would be for people who did not respond to the initial treatment or did, but
Both.
now, okay.
Both.
All right.
It
All
doesn't matter whether you've responded or not.
Okay, but
you
now
need a treatment.
Okay, got it.
It's going to work because
Okay.
your previous treatment's not working anymore.
Understood.
So lapatinib is a dual inhibitor of HER2, but it also inhibits EGFR. And so definitely EGFR plays a role in many cancers, many breast cancers. And there are some unique treatments regarding that, triple negative, and other approaches. So the concept was, let's inhibit EGFR pathway 2 at the same time. The trials for lapatinib have not been the greatest.
What does that mean?
Well, it's inconsistent.
Oh.
And, I think it really requires, once again, tumor DNA sequencing, as with any of these drugs.
So, so there might be a problem with how the trial is being run and how they're vetting people for inclusion.
You want to have, you want to know that your patients have some sort of EGFR process going on, obviously. Okay. So the real change is a drug called TDM1. And that's basically trastuzumab, which is the molecular name for Herceptin, the first HER2 inhibitor that we talked about. And so it's been combined with in something called emtansine or emtansine. And that's the name of the drug. I just call it TDM1 because it's easier to say. And so it's a drug conjugate. So it's got this HER2 monoclonal antibody, and it's got a chemotherapy drug combined. So it's considered targeted chemotherapy. And conjugate drugs, we're seeing a lot more of them. They can be very useful, where you combine an antibody that binds to a cell surface receptor and then has a chemotherapy payload. And I think we're going to see a lot more of these. They work quite well.
And what makes them work well? What's actually happening in there?
They're targeted.
Okay.
So instead of a chemotherapy drug that affects all of the cells, these have a monoclonal antibody that takes them to the tumor.
Right. Because the concept of chemotherapy, it isn't a bad one, is it? This idea that, that cancer cells can be
targeted chemotherapy is the way to go, obviously.
Right. Yes. Because then it's directed right where it's supposed to be and not to all of the stem cells in your body.
The downside is it's not going to affect cells that don't have HER2 expression.
Okay. Which again, back to the genetic testing, so that we know.
And back to the ratio of HER2. As I mentioned, it's not going to be consistent throughout all of the body cells.
Yeah. Okay. So genetic testing and the ratio are two important.
And just understanding that HER2 is going to be changing throughout the course of the disease, and it's going to be different in different cells in the same tumor. So that is the downside of it. Otherwise, it would be a cure.
But that is where the liquid biopsy monitoring comes in.
Yeah.
Because
exactly.
then you can tell as you're taking your treatment.
You can tell if it's getting rid of those HER2. So interestingly enough, this drug has been much more effective in the later stage. So in patients that have been heavily pretreated. And usually patients that have been heavily pretreated do not respond so well. But
you mean independent of this drug? You mean?
Yes, independent of this drug.
Okay.
They have a lot of heterogeneity in their tumors.
Okay, and that's the TDM1 you're talking about.
Yes. So for some reason, TDM1 really is incredibly effective in this late stage. Now, they're also trying it in early stage, and it seems to work quite well in early stage. But for some reason, it just really works better so the more treatment lines patients have had, the more drastic of an effect they get from this drug.
Interesting.
So they could be at the same stage, but with different lines of treatment. But if they've been heavily pretreated, which is normally a bad thing, they tend to respond better. And no one can explain why. We don't understand why yet. We're looking at the mechanism.
It's like all those previous treatments have primed.
That's the theory. Yes, that's the theory. They think there's some sort of priming going on, but we don't quite understand it yet. And so in those patients, the hazard ratio, that means the hazard of death, is 0.5. That means a 50% reduction in death for these patients that would normally have no treatment options.
Wow.
It's really great.
That's awesome. So if you know someone who has late stage HER2 related cancer and they've been told there's nothing more that can be done, not necessarily the case. That's what you're saying.
Yes. So So now, obviously, there's people with HER2 that have a variety of different other mutations. And so you have people with HER2 positive cancer that also have ER positivity.
Mm.
And that can really affect how these drugs work. The studies in TDM1 show that, that regardless of whether you have ER positivity or not, if you are HER2 positive, this drug works pretty well similarly in both populations.
Wow.
I think there was a 10% reduction in benefit for people that were ER positive versus ER negative, but it was really close. You know, it was still similar outcomes. So the one problem is it doesn't have CNS activity. It's the you know, for brain mets, CNS is the metastasis of the central nervous system. So as you know, the big problem with HER2 positive cancers is the preferential metastasis to the brain. And so that is a bit of an unmet need. They were hoping that TDM1 would be better than Herceptin and pertuzumab for brain mets.
Crossing that barrier.
Yeah, but it doesn't apparently. It's not able to.
Why
So it's similar.
Can we not
Similar.
just inject straight into the head?
Well,
and
yeah,
do we
that's
not do
been
that?
done too, but I mean, these drugs don't last that long and you have to keep doing it. So how do we deal with brain mets in HER2? Well, there's a lot going on there.
Okay.
So you know, once again, tumor DNA sequencing, because you want to know what your co-mutations are. So if you have co-mutations that can open up the door for a secondary treatment or a secondary drug to go along with your TDM1, for example, then you can have a drug that does target the brain.
Or can get across.
Yeah. So one example that I think is really great, and I've been watching for a while now, is, as we mentioned in ER positive breast cancer, there's the CDK4/6 inhibitors.
Okay.
They target the CDK4/6 cascade. There's three of them. There's palbociclib, then there's ribociclib, and then there's the new one, abemaciclib, which is my favorite. Now, I believe palbociclib and ribociclib do have, palbociclib was the first generation of the drug. And it was then ribociclib came along, and it has some CNS activity, but not very much, because these are monoclonal antibodies, or sorry, these are kinase inhibitors, so they are able to get some you know, some passage across the blood-brain barrier. But abemaciclib, the third generation of the drug, has actually really good CNS activity. So a new study is looking at CDK4/6 inhibitors and TDM1, and the preliminary results are phenomenal. You know, they're getting really good results. Unfortunately, they looked at ribociclib. They didn't look at abemaciclib, and abemaciclib is the one with the CNS activity, the proven CNS activity. Yeah. So we're going to see.
So you know it's going to be even better, though.
It's going to be even better. Yeah. I mean, you know, these things you can just predict them. You know,
when you know the mechanism.
Of course, you need a trial, but when you understand the mechanism, and there's so much data to back up the different mechanisms. So for me, if you had, you know, a brain met, I would get on the abemaciclib and the TDM1 combination. And then there's another one, apelaciclib, and that is for patients with PI3K mutations.
Okay.
So if you have a PI3K mutation, apelaciclib is a alpha-specific inhibitor. The PAN inhibitors don't work. You have to use an alpha-specific PI3K inhibitor, because the PAN inhibitors have too many side effects for you to be able to reach a therapeutic dose. So when you focus just on the alpha, you get wonderful results. So, you know, we've been recommending apelaciclib for patients ever since we got the FDA approval.
For specifically for HER2 related cancers, or for
just for PI3K, independent of HER2.
Okay.
But now we have a study with apelaciclib and TDM1, and these are patients that were HER2 positive that also had a PI3K mutation.
And what are we seeing in that?
We're seeing incredible CNS activity. So
it is getting across.
It's getting across, because apelaciclib does cross the blood-brain barrier. So the secret is by going beyond, looking at the genetics and going beyond the standard HER2 approaches.
Mm-hmm.
Because you may have one of these targets that allows you to use a drug that does cross the blood-brain barrier.
And that's going to make it so those metastases are...
So there's also, in clinical trials, HER2 positive breast cancers are recently been able to there's some preclinical studies showing that they retain their sensitivity even after they become resistant to HER2 treatments. They still retain their sensitivity to PARP inhibitors. So if you have a HER2 positive breast cancer patient that also has a BRCA1 or 2 mutation, then you can combine it with a PARP inhibitor. So TDM1 and PARP inhibitors are being tested right now. We don't have a lot of data yet, but the preclinical data really showed that this is the way to go. And then finally, the one that I'm really excited about is the immune therapy. We know HER2 is a stem cell marker. It occurs in many different stem cells. And HER2 positive tumors tend to have a higher infiltration of tumor-infiltrating lymphocytes. So once again, when you get into immunotherapy, whether you're going to respond to immunotherapy or not is all going to be dependent on a variety of factors. One of the newest factors that we know the most about is how many tumor-infiltrating lymphocytes do you have. And so what these are these. So you have two different categories of lymphocytes. You have Tregs, which are called regulatory lymphocytes, and then you have TILs, tumor-infiltrating lymphocytes. So the Tregs are hijacked by the tumors, and they supply the growth factors to the tumors. So if you have lots of Tregs, it's a bad thing. If you have lots of TILs, it's a really good thing. So the TILs get attracted in there to attack the tumor, but they get inactivated by PD-1. So if you have this mass amount of TILs in your tumor, and then you get the PD-1 drug, there's no question you're going to get a response. You know, you're going to get a significant response because those T cells are in there, they're dormant, but they're just being turned off by PD-1. So as soon as you get a PD-1 inhibitor, then it's going to blow it out of the park. So what we know is a lot of HER2 positive tumors have high TIL ratios. So so this is really important to look at the pathology. This is one of the things we do whenever we look at a pathology report. We want to see if there's a high level of TILs, you know, of lymphocytes in the tumor, because then that tells us this person has a good chance of responding to a PD-1 inhibitor. So there was a recent trial where they combined immune therapy, PD-1 inhibitors, with Herceptin. And what they found, so there's two studies. There was a study that was mostly Canadian that failed. And what they did in that study is they only looked at patients that were PD-1 negative. And PD-1 is not a good indicator on, you know, I think this study was flawed in many ways. I'm going to get into that. But there was another study, the Panacea study, and they looked at PD-1 positive patients. And what they found is that if you had PD-1 positivity in addition to high TILs, and they kind of go hand in hand, it's hard to find PD-1 positivity without having high TILs. Interesting. But if you had PD-1 positivity and a high number of TILs, then the overall response rate in these heavily pretreated patients was 39%. The disease control rate was, I think, 47%. So obviously, it's about looking at the pathology and the molecular features before you come up with a combination of drugs. So I think this is a new way to treat HER2 positive tumors. This combination. And a lot of HER2 positive tumors are going to have high levels of TILs.
So that's excellent.
Yeah.
It's going to be very positive.
But this brings me down to one final point. PD-1 is normally tested for in the tumors. I mean, we get it with Foundation 1. They look at the tumors and they say that. That works great in lung cancers, but it's kind of failed in other types of cancers. What we now know is that when you're looking at breast cancers, PD-1 expression on the tumors doesn't mean a thing. It doesn't mean it can't tell you whether you're going to respond or not. And a lot of trials are still looking at tumor-based PD-1 expression, and this is where they really screw things up. You have to look at PD-1 expression on the immune cells. And so there's actually a new PD-1 test that looks specifically at the immune cells. And so this is only for breast cancer. So if you look at the immune cells for PD-1 expression, then you're going to have a better determination of whether these PD-1 inhibitors are going to work in the breast cancer, regardless of whether it's HER2 or ER or triple negative. So once again, you know, the testing and the diagnostics is really key. And, you know, that's why a company like us is so important, because we do go to these lengths and really look at these individual factors.
That's true. Very personal.
Very, very important. And, you know, you may have two patients with the exact same type of cancer, but one has a high TIL ratio, the other has a low TIL ratio. And maybe they test one of these patients, they test the tumor. Sorry, your foundation one said that your tumor was PD-1 negative. We can't give you immunotherapy. And, you know, then that same patient, if they had that tumor retested through and had the immune cells surrounding the tumor tested, and they were PD-1 positive, then obviously they would be a good candidate for a PD-1 inhibitor combination.
Yeah, and that not only does that influence the kind of therapy that your doctor will offer you, but also what kind of coverage you could get it depending on where you live in the world. So some people have to pay for healthcare, some is covered, certain treatments are covered, certain aren't. So having the proof that you need something is really important to get your doctor's approval, of course, to prescribe it and administer it.
Thank you for watching CTOME TV. Subscribe below and stay informed.